Let's proceed.
Okay, good evening once again. Welcome to today's case. We're going to present a random case from HumanDx that I've chosen for David. So, to start with, this is the case of a 39-year-old male who presented with abdominal and testicular pain.
Okay, just like I said, some very interesting things that I do not encounter usually. So, abdominal pain. I think abdominal pain is very broad, and therefore I'll just wait until I get whatever HPI is there to see what is going on. But again, testicular pain is not something that we deal with frequently as physicians. But when you talk of testicular pain, I think we've discussed a couple of cases here of patients who presented with testicular pain, and I do not have a specific schema for testicular pain. So basically, what I try to do is I just think of the limited number of differentials that I have, and then try to see if the presentation matches that. So there's a number of things. Someone presents with testicular pain, so the pain could be due to an infection. So you talk of epididymochitis, and there's a number of organisms which can cause that. So we know STIs. You talk of chlamydia or gonococcal infection. Epididymochitis can be a complication of untreated STIs, and then someone can present with. I think the case, one of the cases I was referring to, we discussed the case of mumps here, and Joseph presented that case to me. So, mumps virus is another cause of testicular pain, or chitis, a complication of mumps, and then so those are just examples of infections. But then you can have testicular pain which is vascular in origin. So when you have testicular torsion, and therefore the blood supply to the testicles is compromised in a way, someone will present with testicular pain. So I have a limited number of differentials, but then when I get the HPI, I think it will clarify some issues, and maybe I can make some progress, but overall difficult.
Thank you. Let's see what the FPI has to say. So, 1 week ago, patient noticed a gradual onset of right upper abdominal pain and testicular pain. Abdominal pain was dull in nature, continuous, but with intermittent worsening following meals. Abdominal pain has limited his eating, and he reports to have lost 2 kgs in 1 week. But he denies nausea, vomiting, constipation, diarrhea, yellowing of eyes, abdominal distension, or shortness of breath. The testicular pain was mostly on the left testicle, but he denies testicular swelling, fever, chills, rash, urethral discharge, painful urination, hematuria, or urinary frequency. Review of other system is non-contributory. Past medical history, non-contributory. Family social history, he has a remote smoking history, quit some many years ago. He's only sexually active to his wife. His mother has IBD, and patient doesn't drink alcohol.
Yeah, interesting. So one of the difficulties I'm having is connecting these two things, although they are not a lot of inches apart, but then uh, I cannot really think of something from on my toes, on just thinking on my feet, on what can explain upper abdominal pain, right upper abdominal pain. So I consider that to be the right upper quadrant, most likely the right hypochondriac region, and in association with testicular pain. Difficult to think of a condition like that one. So I'm just excited to see what the resolution of this case will be. But then, so starting with this abdominal pain, it's rather acute. It's not something that it's not something that is very it's not something chronic. Although one thing that we should remember is that the categorization of conditions or clinical presentations that we commonly use into acute and chronic. If something is chronic, uh, of course it's very likely, if there is no progression, it's very likely that you are talking of something chronic. But then there can be an acute presentation on top of something chronic. But then when you talk of something acute, it could be acute, meaning that is truly acute. But then it could be that you are dealing with something that is of insidious onset, and something that has been playing out for a while, but then symptoms are just coming up abruptly, and therefore you are fooled to think that this is something acute, but in reality it's something chronic. So a theoretical example would be someone presents with what we would term an acute, it will not fit perfectly, but an acute presentation of focal neurological deficits. And then, of course, when you talk of something vascular, it's hyperacute, but then could be, so for example, someone is having a tumor that has been growing slowly for a while, and then all of a sudden they present with focal neurological deficits, and you pay attention to acute causes, which is very warranted. But then it turns out that it's something that is chronic. But then the presentation has been acute because of the natural history of that condition. So I'm thinking 1 week presentation, and then the patient in just 1 week, the patient has lost 2 kgs. Of course, the explanation could be because of reduced intake, because of the pain. So the presentation seems acute, 1 week presentation, and it's mostly on the right upper abdomen, and then the testicular pain is also present for the 1 week. So these two things are starting at the same time. So my thoughts would be, uh, so what we try to do always is to connect the two, to find one explanation for these two things. That is the uh, right upper quadrant pain and testicular pain, which is more on the left. So I'll try to make every effort to see if these two things are connected. But then, if we fail to do that, of course, it could just be a coincidence that they are two separate pathologies, but then they happened to occur at the same time. So I'll start with the initial assumption that it's probably one condition that is explaining both. So this upper abdominal pain is dull aching, and it's continuous, but then intermittent worsening following meals. So when I think of when I approach problems that come with abdominal pain, I use an anatomical approach. That is to think about what organs are found beneath the area that is hurting. So when you think of right upper quadrant pain, you have the liver there, and you have the gallbladder as well as the biliary tree in general. So one of the things that come to mind quickly, my first thinking is pain that worsens with meals, and that pain is localized to the right upper quadrant. I think about pain that is gallbladder, that is coming out of the gallbladder, or is biliary in origin. So, for example, if someone has cholelithiasis and they eat fatty meals, one of the things that we talk about frequently, they eat fatty meals. Fatty meals will trigger, will because emulsification is needed, and therefore the gallbladder is activated to produce or to release bile, and therefore the pain worsens. So biliary pain is one of those possibilities. So cholelithiasis particularly is one of those considerations. But then hepatitis. So the liver sits beneath the right upper quadrant, but then we do not really explain pain that is coming out of the liver to worsen with meals. And another thing is this demarcation can be arbitrary, but so if this pain was in the epigastric area, our list of differentials would grow broader and broader. But then, just to be safe, we also need to think about other things, although we know that the pain is more localized in the epigastric area. So you talk of pain of acute pancreatitis, for example. Um, but then again, the pain of acute pancreatitis, it doesn't have, although again, theoretically, we could say that some meals can worsen that pain. And those theories have led to some sorts of restrictions in patients with acute pancreatitis. But then we do not expect pain of acute pancreatitis to occur in the right upper quadrant. So it's mainly in the epigastric area. But so just to broaden our list of differentials and to make sure that we do not leave anything out. So the liver and biliary system in general, and then peptic ulcer disease and gastritis in general, will expect the pain to be more in the epigastric area, as well as acute pancreatitis. So uh, I think I'll bank more on the biliary tree, including cholecystitis or cholelithiasis particularly, because the patient is not having fevers. We cannot completely say that there is cholecystitis, but at least cholelithiasis is one of those possibilities. So the weight loss, as I said, reduce the caloric intake could explain the weight loss, but other possibilities, now we should ask ourselves a question that this rapid weight loss of 2 kgs in 1 week, this is very tremendous. Is it just impaired intake, or is there ongoing inflammation? And when we think of inflammation, we think infections, autoimmune disease, as well as malignancies. Now, we do not expect malignancies to play out this much acutely, that in just 1 week, someone is presenting with abdominal pain and then testicular pain and then 2 kgs weight loss. But then, so I think I'll entertain that distant possibility, that I'll ask myself a question. Should I also consider a possibility that the weight loss is not merely due to reduced intake and maybe there is inflammation? So I think I already discussed infections, but in the context of testicular pain, not in right upper quadrant pain, but then autoimmune diseases. So an autoimmune disease that can present with right upper quadrant pain and then testicular pain. Had to think about that. So I think I'll wait more and see what examination, if examination can help me make some progress. But with the remaining bullets, so no nausea, vomiting, which are symptoms that are associated with some of the things that I discussed, although the absence does not completely rule out these differentials. And then testicular pain is more on the left side. There is no testicular swelling. I was talking about epididymochitis. That is one of the presentations. There is no fever, no chills, no rash, no urethral discharge. I was talking about epididymochitis as a complication of urethral discharge syndrome. So all those things, painful urination, hematuria frequency associated with urethral discharge syndromes, which can complicate to epididymochitis. And so it's just left testicular pain, no swelling, no other symptoms that are in keeping with some of the differentials that we are talking about. Review of systems unremarkable, and then a remote history of smoking. Otherwise, the patient doesn't drink. Mother with history of IBD. So, inflammatory bowel disease can have extra intestinal manifestations, including uh, primary sclerosing cholangitis. So primary sclerosing cholangitis, we do not expect the presentation to be just, although yes, that increases the risk of also formation of stones because of stasis that happens. But then would expect other presentations like jaundice, which we are not seeing in this patient. And of course, inflammatory bowel disease, the commonest presentation is uh, gastrointestinal symptoms, so diarrhea, hematochezia, which we are not seeing in this patient, and therefore it's a family history. We keep in mind that there is a family history of autoimmunity, but then I do not see a very strong signal of that in this patient. So let's just proceed to physical examination. I'll see if I can make some progress.
Okay, thank you very much for that discussion. And general exam, patient is alert and oriented. He is in no distress. He's a febrile, not pale, not jaundice. There is no oral lymphedema. Blood pressure, 190 over 95. He says this is new. Usually have normal blood pressure. Pulse rate normal, respiratory rate, temperature, and starting normally in the male. Systemic exam for abdomen. Abdomen is not distended, but there is tenderness at the right upper quadrant and the epigastric region. Negative Murphy signs. Genitourinary system, tenderness of the left testicle without swelling. Also, neuro exam, there is decreased sensory sensation of the light anterior thigh. The rest of the neuro exam is normal, including power. Other systems were normal.
Okay. So I see more layers of complexity coming up. So a blood pressure of 190 over 95. So this is so for this patient, I'll just say a hypertensive urgency, because I do not remember, or at least maybe if I've missed something, I've not heard of anything that is in keeping with features of end organ damage, which I would qualify to call that a hypertensive emergency. So, markedly elevated blood pressures. So, someone who has exquisite pain can present with elevated blood pressures, but I think this is for me this is too elevated to say it's just because of pain. So does it well, what it does is it adds complexity, because this is a 39 years old male. We have been told that there is no significant past medical history, and then now we see what is this the final stage, basically your grade of hypertension, 190. That is very high. So systemic examination, again, just tenderness. So tenderness in the right upper quadrant, and then epigastric tenderness. Yeah, so I started discussing some differentials here. Negative Murphy sign tells us that no cholecystitis. And yeah, so the tenderness is on the right upper quadrant and then the epigastric region. As I said earlier, that the demarcations are arbitrary. So this tenderness, I think we can expand our list of differentials and include some of these other things that we are talking about. But then, if you think of something like acute pancreatitis, for example, this will be, if we are talking of acute pancreatitis, this will be a very mild form of pancreatitis. So commonly, pancreatitis will present with other things. There could be fever, you could see the features of a systemic inflammatory response syndrome. So fever, tachycardia, and then some features that you can pick on your full blood picture. So we are not seeing at least the physical signs that are in keeping with that. So the tenderness is on the right upper quadrant as well as the epigastric region. But then when we go back to the nature of that pain, it's not pain that is in keeping with peptic ulcer disease. For example, we're told it's dull aching, intermittent, but worsens with meals. But again, so if you think one thing that I'm constantly trying to do is trying to Venn diagram these two things, the abdominal pain, and now we know that there is ongoing inflammation of some sort because we are picking tenderness. Tenderness is one of the cardinal manifestations of inflammation. So there are some organs underneath the epigastric region and the hypochondriac region that are the right hypochondriac region that are inflamed, and the same applies to the testicle. So what the left testicle particularly. So what I'm trying to do is to Venn diagram these two things, epigastric plus what is very likely right hypochondriac region tenderness, and then left testicular tenderness. So what one thing can explain these two things, and then to complicate the matters further, we pick that there is decreased sensation on the left anterior thigh. So I'll tell you that I think I'll have a hard time remembering these dermatomes. But basically, so a reduction in sensation. What does that tell us? So one quick assumption would be we are dealing with the sensory neuropathy on that area. When you have reduced the sensation, basically what you are talking about is that there is a problem with sensation, so most likely a sensory neuropathy. So what exactly is going on? And it is that dermatome. So let me see. That is the territory of L1, L2, L3, L4, L5. Yes. So most likely L1, L2. That is the dermatome. So I'm thinking, what is happening to the sensory nerves, to the sensory nerves that are originating from the L1, L2 nerve roots. And because we are not hearing any motor symptoms there, so that means whatever is going on is not involving so it's not a problem of the mixed nerve, meaning a combination of motor as well as sensory. It's just sensory. So what is happening there to the sensory roots particularly, and does that have a connection with the abdominal pain that we are hearing, and the testicular pain, that we are hearing on or that the testicular tenderness that has been picked on the left side? I'm having a hard time to connect those two things. So just to represent this problem again, a 39 years old male with no significant past medical history presents with a 1 week history of right upper quadrant pain and left testicular pain. And this pain is dull aching, intermittent, worsening with meals, and it has led to reduced intake and a 2 kilograms weight loss over 1 week. However, there is no fever, no chills, no rash, and the patient has no testicular pain or a history of any other genitourinary symptoms like urethral discharge, hematuria, dysuria of frequency. And then physical examination peaks markedly elevated blood pressure, right upper quadrant and epigastric region tenderness, as well as left testicular tenderness, and then decrease the sensation in the dermatome of L1, L2, if I'm very correct. So uh, that's the issue. Now, I'll tell you, nothing clicks up to this moment. So let's proceed to labs and anything else that you have. I'll see if I can make any progress. But overall, I'm having a hard time.
Yeah, it's a bit of a hard case, but it will be obvious later. Don't worry. So the labs, CBC, renal, electrolytes, liver functions, and the enzymes are normal. Urine analysis was normal. So they performed a swab for the throat, anal, and urethra, and sent for PCR. It was negative for Neisseria, gonorrhea, and chlamydia. Hepatitis B, hepatitis C, HIV, they were all negative. ESR was 11, CRP 1.2, ANA 1:320, double-stranded DNA, anti-JO1, anti-RNP, anti-SCL, anti-smooth mass antibody, SSA, SSB, ANCA, anti-cardiolipin, complement 3 and 4 were all within normal limit.
Okay. Yeah. So starting with the CBC. So some of the conditions I was talking about, like in the list of differentials, if you pick epigastric tenderness, for example, acute pancreatitis, so commonly can present with leukocytosis and even so, for example, also conditions like cholecystitis. So commonly would expect a fever to begin with in both of these conditions, although absence does not rule them out, and then abnormalities in the CBC would not see any of that. And then, so thinking of the liver particularly, as well as biliary tree pathologies. So the liver function test, I believe here have included also liver enzymes. So if you have something like biliary obstruction, would expect to see a cholestatic picture when it comes to the enzymes like ALP, GGT, which I'm assuming the liver function tests that are reported here also include the enzymes. They are not elevated. And then urinalysis is normal. So right from the very beginning, I talked about these two organisms, gonorrhea as well as chlamydia, as a cause of urethral discharge syndromes and then complicating to epididymochitis. And these ones are negative and the urinalysis is normal. So generally, with the urethral discharge syndrome, we would expect to see at least some hematuria, a leukocytosis, leukocytes in the urine, which we are not seeing in this patient. And of course, presenting with testicular pain, another thing is so testicular pain can be referred. It can be referred, and one condition that can present with referred pain is when you have ureteric stones. So that pain starts in the loin, but then it can radiate to the inner thigh and even in the testicles. But then ureteric obstruction again not 100% sensitive, but then you could see some abnormalities like some RBCs in the urine. But then even the nature of that pain, so pain of ureteric obstruction, for example, ureteric stones, has no relationship with meals. Yes, it's colic in nature and can be intermittent, but then it has no relationship with meals. And so if we had of lung pain to begin with, and then we could consider this as radiation, but then there's a number of features of that pain that is not in keeping with ureteric obstruction. So a normal urinalysis and these organisms have been ruled out. So triple serology negative, so hepatitis B, C, again, yes, right upper quadrant pain, but then the nature of the pain that we had was not in keeping with hepatitis. Inflammatory markers are within normal limits based on my memorized. So, for example, CRP, I use a cutoff of 0 to 5. So, if that is the case, the CRP is normal, ESR normal. So the ANA, I think I'll need your help here, Joseph. Is this tighter? The way I see it, it looks like it's elevated. Is that correct? Is this an
Yeah, it's
elevated?
elevated.
Yes. So an elevated ANA, but then there is one thing up to this point. Although yes, so when I was talking about the weight loss, and I asked myself a question: is there ongoing inflammation? And if there is ongoing inflammation, autoimmune disease is one of those considerations. But then I have not come up with an autoimmune disease up to this point. So one thing that I live with up to this point is that if I'm not suspecting an autoimmune disease, which I've not completely ruled out in this patient, I'll try to think and see if things are tallying with any autoimmune disease. But then, if you are not suspecting an autoimmune disease, do not order autoimmune markers, because uh, you can have false positives. So up to 5% of the healthy population can present with a positive ANA, and that proportion will keep on increasing as age increases, and therefore if you just order it blindly, it might come positive, and then you make matters more complicated, because you are not seeing features of any autoimmune disease, but then the ANA is positive. But we see an elevated ANA, and then so other things: double-stranded DNA negative, RNP, JO1, SEL for systemic sclerosis, SSA, SSB for Sjogren's, ANCA for ANCA-associated vasculitis. All these are within normal limits. So the labs, everything else unremarkable except for an elevated ANA. So what exactly is going on here? And I saw a message from Antimon. Let me see. Maybe this could be of help. So vascular in origin, abdominal aneurysm. So could it cause reduce the sensation at the dermatomes L1, L2? Well, so uh, an abdominal aneurysm. For example, if you're talking of an abdominal aortic aneurysm, it does present with abdominal pain. But the abdominal pain will definitely not likely to be associated with meals. Not likely to be associated with meals. And then the dermatomes that we've been talking about, L1, L2, so the roots where they are coming out is very distant from where the abdominal aorta is passing, and of course a short course, and then it divides into the iliac, the celiac trunk, and all that. So if we are talking of for example, compression, not likely with an abdominal aortic aneurysm, for example. So entertaining something vascular, it would need to explain all these things, that right upper quadrant pain, which worsens with meals. And when you think of right upper quadrant pain that worsens with meals, the list of differentials get narrow, because even hepatitis not very likely. So most likely you are talking of something that is biliary in origin, like cholelithiasis, And then because the tenderness was epigastric and right upper quadrant, peptic ulcer disease, the nature is not in keeping, but then of course peptic ulcer disease pain can worsen with meals. So another thing is someone can have a vasculitis. I mean, can have abdominal pain that is vascular in origin, and so this is mesenteric ischemia. But then mesenteric ischemia, mesenteric ischemia will not explain right upper quadrant pain, not very much. So the pain of mesenteric ischemia, it will worsen with meals, and of course it will cause the patient to have reduced intake, because if whenever you eat you worsen abdominal pain, then people opt not to eat in order to avoid the pain. So mesenteric ischemia is one of those things that can present with abdominal pain, but then this pain is it's hard to localize it because the mesenteric vasculature is throughout, and therefore it's dull aching, of course, worsens with meals, which we term as intestinal angina. But then the location here, I think, is what was distracting me. So the list of abdominal pains that worsen with meals, mesenteric ischemia is one of those. The nature of the pain is in keeping, but then the locations, I think those are what are making me hesitate. And then cholelithiasis worsens with meals, and then peptic ulcer disease can worsen with meals, especially when the ulcer is gastric, can worsen with meals. So I have those. So another one, as I said, of course, pancreatitis can be in the pain of pancreatitis can be in the epigastric area, but then I have not seen some other things that are in keeping with pancreatitis, but I see those are at least some of those things that I have. But then connecting this now with testicular tenderness and elevated blood pressure, of course, they could be separate pathologies, and reduce the sensation in the left anterior thigh. That is where I'm having issues. So if we are talking of mesenteric ischemia, for example, and we think of a vasculitis, we think of a vasculitis. So this vasculitis, how does it explain right upper quadrant pain? I'm having an issue there. If we talk of the mesenteric ischemia being because of, and of course this patient has a remote history of smoking, but then we didn't hear about the severity about the pack years in order to see, because mesenteric ischemia, smoking could be one of those, diabetes is another one, but then vasculitis syndromes could be another one. So a vasculitis syndrome having issues. So there's another issue here, right? Renal artery embolism. Well, so renal artery embolism. So when you have an obstruction when you have impaired supply to the kidney, we would expect some abnormalities, because that kidney is becoming ischemic. Of course, we could say that the other kidney is compensating, but then because if it's ischemic, then we expect that there will be some changes that are in keeping with that ischemia. So basically, even the glomerular function will be impaired. So there could be some things in the urinalysis. So that's an assumption that I'm making, but then we'll see what is coming next. And what complicates this matter is that the abdominal pain is in the right upper quadrant, and then the testicular tenderness is on the left. See, so if these two things were on the same side, then we could think about one pathology that we would consider possibility. Is it vascular in origin that is explaining both the right upper quadrant tenderness and then right testicular tenderness, for example? So what complicates it is the testicular tenderness is on the left side. So I'm thinking of those things. A vasculitis doesn't explain all these things. And then, so apart from that, so there are things like so and now this is I'm trying to throw out some differentials. So for example, one of the autoimmune diseases that can be associated with the vasculitis or is some sort of a vasculitis itself is Behcet's. But then we've not heard of other things that are in keeping with Behcet's in this patient, like ulcers, for example, oral ulcers being one of those things. But then, so Behcet's is one of those conditions that can come with a vasculitis, could explain mesenteric ischemia, and I'm thinking whether I've read about a testicular presentation in patients with Behcet's somewhere. But then, of course, because my knowledge on that is limited, I'll not try to be shooting in the dark. So I'm still having difficulties. So I'm thinking, is there some imaging, Joseph, that you have which can help me make some progress, or any other
Yeah,
labs that
yeah.
are remaining?
We have imaging.
Yeah, let's proceed.
Thank you. Yeah, so here's the testicular ultrasound, which shows bilateral testicular complex cystic lesions. And they also did the contrasted CT abdomen pelvis, which shows a celiac artery thrombosis with concern for vasculitis, and circumferential wall thickening and irregular fusiform aneurysmal dilatation of the common and proper hepatic arteries. That's the last aliquot.
Okay, yeah. So let me see this. So bilateral testicular complex cystic lesions. Well, I so if I was very good at or if I was a radiologist, or if I had come across this some other time, then I should have had some differentials. When you hear cystic lesions in the testicles, what differentials do you need to consider? So I really don't have differentials here. Let's see the next one. Yeah, so concern for vasculitis. So vasculitis has been a thing that I was throwing around a number of times, and then so celiac artery thrombosis, and then circumferential wall thickening, and irregular fusiform aneurysmal dilatation of the common and proper hepatic arteries. So when you hear of wall thickening, what that tells you is that there is inflammation, wall thickening of those vessels, and then the aneurysmal dilatation could be because of this inflammation. So basically what we are saying here is that there is arteritis. There is arteritis because there is wall thickening and then aneurysmal dilatation, which is a complication of whatever inflammation is going on in these vessels, and it's both the common as well as proper hepatic arteries. So there is arteritis. So when we tally these now, and again, I think I'll leave some details undiscussed because I'll miss out some things. I'll not remember everything probably, and of course because of limited knowledge for others. But then when we think of inflamed arteries, so that's a vasculitis. Definitely, that's a vasculitis. Now, one question comes: So what kind of vasculitis is that? So when we are dealing with the vasculitis, yeah, we have to think about, is this a large vessel vasculitis? Is it a medium vessel vasculitis, or is it a small vessel vasculitis? So large vessel vasculitis, an example is Takayasu, giant cell arteritis. And then for medium vessel vasculitis, the most famous and the only one that I remember is polyarteritis nodosa. And then small vessel vasculitis, we know some of those. So when you talk of ANCA-associated vasculitis, like GPA, those are small vessel vasculitis. So the hepatic arteries, I consider these to be medium vessels, medium-sized arteries, and therefore I remain with one differential here, which is polyarteritis nodosa. And I'll be honest, I'm making this, so this is a differential that I'm throwing out there because I was concerned about a vasculitis when I saw an elevated ANA titer, and then the abdominal pain that was worsening with meals, and then we are not seeing cholelithiasis. So the question came, is it a vasculitis? And then imaging is telling us that there is a wall thickening, there is aneurysmal dilatation. So I'm thinking it's arteritis. And therefore, the only differential that I have here is polyarteritis nodosa. But because of my limitation in knowledge, I think it would be safer to say that because of these features that we've seen here, abdominal pain, elevated ANA, and then the nature of that abdominal pain, which is concerning for probably mesenteric ischemia, and we have a concern for vasculitis. So it would be safe to say that we are dealing with the vasculitis syndrome, which is involving the medium vessels, and that is bringing us to the same conclusion that polyarteritis nodosa is one of those. But then there could be other differentials that are missing. Now, does it explain the hypertension that we are seeing in this patient? I'm not sure, but that could be the case. Does it explain the testicular pain and tenderness that we are seeing in this patient? Again, I'm not very sure, but because the medium vessels are involved, that could be a possibility. Now, the cystic lesions that are seen in the testicles, as I said, I do not have differentials for those, but then hopefully in the teaching points, Joseph will tell us. So I think it's safer to say a vasculitis syndrome, but then because it's the only one that I have for medium vessel vasculitis, I would say polyarteritis nodosa. But because of time, I think I'll just need to stop there. And I see that Mike also have the same thoughts. So thank you very much for the help. Joseph, let's, that's an issue, Michael. ESR and CRP are not elevated. So as I said, those are, when I think inflammation, it's one of those things that I look at, but then they are not elevated. So that's another thing that raises questions. But then when we see the wall thickening and then the aneurysmal dilatation, we know that this is arteritis. So the tests are not perfect, but then so I think there's a number of biases here in my thinking process, and those will be uncovered when Joseph reveals the final diagnosis and presents the teaching points, and hopefully that will bring some helpful reflections. So Joseph, take us home.
Thank you very much, David, and everyone in the chat. I think the discussion was on point. And yeah, as you're saying, the found diagnosis in this case was polyarteritis nodosa. And I solved this case some time back, and so it was pretty learning for me. And once you see the imaging, you start connecting the dots from previous, but initially you don't, it's hard to find out. But let's see some teaching points. So as you're saying, if you have vasculitis, you can have large vessel, small vessel, and this medium vessel. So PAN is a medium vessel vasculitis, but it can occasionally involve some small vessels. It can be primary or secondary. The secondary one has a cause, primary is idiopathic, and the causes include hepatitis B virus, as well as they tested it, hepatitis C, and hairy cell leukemia. So the kidney is the most common organ to be involved, but it can affect any organ from skin, neurological. So the anterior thigh reduced sensation was the mononeuropathy of the, I think, the femoral, the femoral neuron that was affected. So even cardiac, GI, muscles, the peak incidence is in the fifth and the sixth decades. Male are slightly more affected than female at a ratio of 1.5 to 1. Presentation non-specific. There can be systemic symptoms like fatigue, weakness, weight loss, fever, arthalgia, this patient had weight loss. But it can have a multi-systemic involvement, like the liver, the kidney, any organ can be affected. So diagnosis, you have to have a biopsy of the affected organ. But sometimes it can be very difficult to take a biopsy. Like in this patient, which biopsy are you taking? That's the vessels that we cannot cut the vessel. So if there is no obvious site for biopsy, you can do full body angio and look for microaneurysms, the linear or hepatic or mesenteric circulation, which were present in this patient. But the American College of Rheumatology is a classification criteria. These classification criteria are usually not for diagnosis, but for qualifying patient to research, but they can help us. Like, so if someone scores more than at least 3 of these criteria, they have a sensitivity of 82% and a specificity of 87% that they have PAN. And these include a weight loss of more than 4 kgs, livedo reticularis, this is a rash, testicular pain, which the patient had, myalgia, weakness, leg tenderness, mono polyneuropathy, the patient had it, and diastolic blood pressure of above 90, this patient also had this. Also, there can be elevated urea creatinine, hepatitis B, arteriographic abnormality, the patient had it. And if you have a biopsy which shows polymorphonuclear cells, so patient scored like 4 of these. Yeah, so treatments include corticosteroids with or without other immunosuppressive drugs like azathioprine, methotrexate, cyclophosphamide, depending on the severity of the disease. Some patients have severe disease and they will require plasma exchange, or if they are not responding to the initial management. So if it discovered that it is secondary to hepatitis B or C, patient has to receive antiviral medication first before they receive immunosuppressive beds, so that the calm, silent hepatitis can't be fulminant and starting bring us other chaos. Yeah, so that was the case today, David. I think the time is up. If you have any reflection.
Thank you, Joseph. So, to begin with, I think this is one of a kind, in that, most of the times, many cases that we've been discussing here, and whenever I happen to get the diagnosis right, most of the times, that diagnosis will be part of the differentials earlier on, whether right from the history or when it comes to physical examination. Commonly, those areas right from the history, that differential might be coming up. So today has been unique in that history all the way to physical examination and then initial labs, still nothing had clicked yet. So up until I saw the elevated ANA, and then I think imaging is what was very pivotal in making the diagnosis here. So overall, it was a very difficult case, and I think I've learned a number of things, and so this is one of those cases where we always say that, many times we say that history, and of course this is not meant to underestimate the help that a good history and physical examination can have. But then there are a few cases in which history exam will not really help you make a lot of progress until you get some help from labs as well as imaging. So I see this is one of those cases. It was tough for me. So new learning today that polyarteritis nodosa, so the testicular pain. I'm not sure if I was right in the cause of uh, about the cause of the abdominal pain that we saw in this patient. Is it mesenteric ischemia? Is it because you presented? I think the thrombus was it in the celiac?
Yeah, and the celiac is it
Okay.
was the cause of the pain.
Okay, so that was the cause of this pain. So thank you very much, and this was a good choice of a case. I know it was random, but then good choice because yeah, it reminds us that medicine is not easy. So thank you very much for the case. So just on time. I saw the chat was active. Thank you very much, Michael, for the help, and very very impressive because I see at the point of imaging you also came up with a vasculitis and polyarteritis nodosa. So uh, uh, that's very impressive, and thank you very much for the help. So do we have anyone with anything to share? Questions, comments? Michael, please welcome.
Uh, thank you, Dr. David. For sure, I second you that the case today was hard. I have one thing to share. During our time, I think we attended one case of vasculitis, either with Dr. Nabil. So Dr. Nabil, Dr. Sebastian, and I, and we shared it for the grand round. It was Takayasu arteritis. But I can declare, regardless all other the readings that we did that time, it was hard to figure out if this was vasculitis up until when we actually the images came out. So this was really a very good case. Thank you very much, Joseph.
Thank you, Michael. Anyone else before we close? If there is anyone with who would like to, whether you have a question, a comment, any experience to share, please welcome. Yeah, I do not see any hands. So like to welcome you back. We took a break last week because of Easter holidays, but we are back. So because we do not have any holidays anytime soon, so every Sunday we meet here for, if there is anyone who is joining for the very first time, we meet here every Sunday at 8 p.m. East African time. So you are very welcome, and this is an open platform. So if you get hold of the link and you want to share with anyone from anywhere, please feel free to do that. And again, we remind people that we need discussants and we need presenters. So if you have a case, reach out to me or Joseph, and you will get a spot to present that case, so we can learn from the interesting cases that you see. And anyone who is willing to discuss, you are more than welcome to stop anyone at the beginning of the presentation and to discuss, so we can also learn from other people. So having said that, it was good having you around, and see you next Sunday. Have a good night.
Good night.